So thank you very much, everybody, for coming to our innovative series seminar. I have a few housekeeping announcements to make before introducing our speaker. So online participants, please keep the mics muted unless asking a question. We always welcome questions. Use the chat feature in BlueJeans if you have technological questions. That's also for online participants. For everybody, all the previous presentations are available on our website, DE-CTR.org. You need to sign in to receive credit, CME credit. We can receive credit online, but use BlueJeans chat to contact Sarafe at start of presentation for receiving credit. And finally, next week we have another very exciting talk, Opportunity and Activism on the Streets of Wilmington, Delaware. And the following week we have another talk, Disparities in Obesity Among U.S. Adolescents with Disabilities. So I'd like to introduce Dr. Alison Karpyn. We are delighted to have you at this seminar and very excited about hearing about nutrition deserves and all these interesting things. So Dr. Karpyn has a BA in Public Health from Johns Hopkins and a PhD in Policy Research, Evaluation and Measurement from University of Pennsylvania. She is now Assistant Professor of Education at University of Delaware and Associate Director of the Center for Research in Education and Social Policy. She's also adjunct faculty at UPenn in the Department of Public Health and adjunct faculty at Thomas Jefferson University in the Department of Public Health. And has been, I was very impressed reading your CV. You've been a guest expert for nutrition issues at WHYY from NPR at a couple of programs. That's really, really exciting. Dr. Karpyn has a long list of publications, and thank you very much for coming.
Yeah, thank you for the introduction. That was very sweet. I wondered if they picked the French woman because it was food and yeah. So thank you all very much for having me. I've done a number of different kinds of research studies related to food and public health, but really the basis of my sort of existence was formulated at an agency called the Food Trust, which I worked at for 12 years, where I was the director of research and evaluation, and I ran the consulting arm there. So a lot of the work that I know and have studied and the context for my work comes from that effort. And so really, I'm going to present on today some intervention trends and research findings. And what I'm looking to kind of share with you is the variety of sort of on-the-cusp activities that are happening, and then some of the research also that is sort of buttressing that alongside some of the policy efforts that we're watching carefully now as Congress is rapidly discussing a lot of issues related to it. So a little bit about my background. I mentioned already that I worked at the Food Trust. Before that, I actually spent some time doing school and school policy, which is one reason why I've come to the University of Delaware now for the Center for Research in Education and Social Policy. So I'm starting to blend and expand upon a little bit of this work broader into education and other social policy issues, so, by way of background. The center, which is CREST, the Center for Research in Education and Social Policy, works to improve communities through research in education and social policy, as I mentioned. So I figured it's useful to think about some of the education and nutrition programming and policy efforts in terms of where they take place on the ground, right? Or about sort of community and community health, and there's no place better than to think about the locations. There's certainly far and wide more activities happening than this, but in this period of time, I thought this would be a nice little snapshot to get over with you. So I'm going to spend a good bit of time talking about some of the efforts happening around supermarkets. This is where a lot of my research is right now, and so I figured I'd bring to the forefront that. Corner stores is another area where a lot of work is happening and continues to happen. Farmers markets, I think there's more and more happening here in Delaware, which is why I sort of brought that one out. There's some new policy activity that's happening, and we'll be rolling out in the summer, and other voucher activities that are happening. And then because I'm at Christiana, I figured I would put in a couple of the recent activities I know about how hospitals are intersecting with food and community work. So we'll start off with supermarkets. So the supermarket effort, for how many of you are familiar already with some of the supermarket policy efforts that have happened? Actually, not so much. So Brian, yeah, maybe a little bit. But so quite a few years ago, I want to say maybe 15, probably about right, the Food Trust began thinking about why it was that we were running farmers markets, and at the same time, when the season was over, folks didn't have a place to buy food. And so it was really through a discovery that started off at very much a community level so I guess I should step back one step further. So the Food Trust was founded as part of the Reading Terminal Market, and that was a bringing together of local growers, and then from there started to be some farmers markets activities, which is when the agency kind of separated from the Reading Terminal Market to its own entity. So anyway, it was at those local farmers markets that we really sort of started to open our eyes to what was happening on the ground with supermarkets. And so we started to do some maps looking at where supermarkets were and where they weren't, where sales were most robust, where population density was high, where diet-related disease, which is always a difficult thing to exactly measure. But what we did was look at death certificate data from when people died and what their causes of death were. And then started to identify where there might be opportunities for improvement. So where are there places where public policy might come into play, where you find an intersection of high rates of diet-related death, of low-income populations, and low access to supermarkets, kind of that negative trifecta. And so based on that kind of early understanding of where these places are, we sort of moved forward to create what ultimately became called the Supermarket Campaign, which was really an effort to bring together supermarket retailers to come to a consensus on what the biggest challenges were from their perspective, so that we could build a policy portfolio to kind of start to bridge the gap between what they said they needed and what was available in terms of resources. So that kind of, there actually is a peer-reviewed publication on that process called the Supermarket Campaign. It was published quite a few years ago. I want to say like 2008 I did that. And so from that process, then what happens is you end up with a framework from which you can build a program. Now, one question that we get all the time, because this is, very much community-based work in many ways, is residents who say, I've got it. You don't need to do all that. What you need to do is you need to build a store right here at the corner of X and Y streets, because there's this old abandoned building, and we encountered that too in Philadelphia before we got started. But Dwayne Perry, who was our founder, who had some experience with community planning, said, you know what, we're not going to do this as a one-off effort. We don't want to see a store here and then negotiate a store there. What we want to see is a program that will allow people who want to do it anyway to be able to do it easier and simpler with some of the resources to bridge the gap. So that process now has been replicated. In Pennsylvania, it yielded a $120 million fund to establish supermarkets in low-income neighborhoods. And then it's been replicated in other states, and I have a sampling of states. These were the first ones to come online. Now there's other states that are also either have just passed or are about to pass other financing efforts, where they've gone through the same process. And really, it's interesting because the financing program is what gets a lot of attention because of the big numbers and the big dollar signs. But the reality is, for example, in New York, part of what came out of that, bridging the gap laundry list of changes that they wanted to see were also things like zoning changes so that you can put parking higher in buildings, build buildings taller so you can have more space for parking. Or the Green Carts program, which has gotten a lot of press in New York City, like the idea of bringing fresh food out onto carts as well. So not just it's not just about a financing program for supermarkets. In New Orleans, one of the issues was around ways to curb the insurance rates for these properties. Sometimes lighting and wanting more policing support is one of the priorities. So it can be any number of priorities, but oftentimes the fund is one that really comes out as a major issue. So these state programs was kind of the heart of where we began, and then it grew to be part of a bigger healthy food financing effort that Policy Link, which is a national organization based in, well, they're in California and New York, partnered with the Food Trust and partnered with the Reinvestment Fund. So when you do this work, there's a couple different important banking entities to be familiar with, and you'll notice here I use two of them. So this is fun. So CDC, it's great when you have bankers and public health people in the same room, because they'll say, "Hi, I'm from CDC," and then someone else says, "Wow, which one?" And he's like, "No, I'm from CDC." "No, which one?" So CDC stands for Community Development Corporation for banking type people, right? So there's lots of them all over the country. I don't know, Brian, do you know the name of some CDCs here in Wilmington?
They're triple Ps. They're public-private partnerships here.
Okay.
So I'm not sure that the specific names.
They're usually small entities, nonprofit kind of groups that are able to redistribute funds for special projects. And then there's another kind of organization called a CDFI, which is a Community Development Financial Institution, which in some ways has the same spirit as a CDC, but is usually a much larger entity, sort of a more sophisticated banking practice with a lot more regulation to become characterized as a CDFI. So what ended up happening is that the Healthy Food Financing Program, which was established by the federal government, ended up being in a couple different sort of channels to access funds. So it was one of the first projects in the Obama administration that overarched multiple departments as one holistic project. So it covered Treasury, Health and Human Services, and Agriculture. Those were the three departments that came together to form this program. So that was back in 2009 when they first issued $77 million. Most of the funding really came through Treasury, but other departments contributed as well. And then in 2011, the Farm Bill included $125 million and also a redesignation. So it had been sort of coupled together right when the administration kicked off, and then it became redesignated as really as its own specific program in the USDA. So it's established there now, and that's its home. And since 2011, it's distributed $109 million to 40 CDCs and 21 CDFIs. And remember, this is just the federal program, and then the state efforts themselves, like for example in Pennsylvania, there were 86 programs developed just through that Pennsylvania fund. So in California, I should know that number. They've also seen comparable establishment of stores in that state too. New York's done really well too. So this is a robust program. They're not all large stores. Some of them are renovations. Some of them are for corner store, smaller store stuff. But for the most part, it's pretty big. And the horse has definitely left the barn, because some of the controversy around this is not without merit, although I think some of it should have is for headlines more than perhaps what the data pans out to say. But this is what we saw. So this is 2012, when two researchers simultaneously came out with findings from two different data sets that there is no relationship between BMI and proximity to a supermarket. So Roland Sturm from Rand Corporation and Lee is her last name. I can't think of her first name. I'm sorry, but she's also in California. Came out with these simultaneous. And then to add insult to injury, Kelly Brownell was quoted in the New York Times as saying, "If you are looking for what you hope will change obesity, healthy food access is probably just wishful thinking." That's the kind of stuff that Marty Moskowitz likes to take on. So this conversation then leads to obviously a review of the literature, right? And a review too of the framework upon which this whole kind of effort was built. So there's a number of different kinds of frameworks that talk about the structure for where these kinds of issues, where the food desert issue kind of sits in the context of all of the possible types of interventions that should be happening. And so this is one example. You all are probably familiar with the Institute of Medicine. This framework, I don't remember what year it was released. It's a little bit old now, but this is still, I think, their kind of working model. So all you have to do to solve obesity is first, it looks like you need trails and some biking, and you need to improve schools. And then you're going to get people to consume fewer calories per plate. And then you're going to tackle fast food. And water is really important. And then marketing to kids, you'll need to tackle that. And then after that, you should really pay attention to healthcare in the workplace. And and then schools, well, we talked about that a little bit, and after school programs. And so then the 5 solutions are really schools, everyday activities, the workplace, available food, and then there's, oh, look, healthy food access right there. So I think part of what the point, that where I stand on this issue is I think we definitely need to do a lot more research on it, but there also is a little bit of a back and forth about how do we move forward if we don't have stores in neighborhoods, which is pretty established, and we're doing education efforts or advising people to consume differently when indeed it's not really there in the first place. So this is another good resource if you're looking for resources on this, looking at the measurement and understanding of food deserts. It's a little bit old now, but it's a good fundamental document. And then these guys also have kind of come out and stood behind the idea that these are the kinds of studies and the kinds of efforts that we need to create a common platform in our communities to be able to reduce obesity. So the grocery gap is one of the first documents, it's the only one I think, that actually reviews a broad range of literature. We updated it again in 2013. And it covered, in 2010, it covered 132 studies. In 2013, we saw this enormous growth and the amount of studies in this area. It doubled in just the 3 years. So there was another 130 studies that came out between 2010 and 2013 on the issue. So it's definitely very much of interest, probably because of the big dollars that are being invested, right? We talked about it. I have a current study on this issue right now funded by the NIH. The NIH has funded 2 studies looking at the impacts of these programs. One is in Pittsburgh, as it turns out, and the other is in Philadelphia and Trenton, and that's this one here. So we're looking at whether or not residents in the neighborhood around a store that is not yet built. Oh, sorry. Who's talking to me? It's not used to being in a hospital, right? Hospitals and schools, bells and announcements. So anyway, looking at the impact that a new store has on the residents who live nearby the store, and comparing that to an area that remains a food desert in Trenton. So we're looking at low-income residents specifically, and looking at the geographic factors associated with shopping and comparing the characteristics. It's only an adult survey too, I should bring that to life. Where this all started was really with some early work that Kim Moreland did when it comes to looking at more of the research side of the relationship between supermarket access and obesity. So Kim has done a lot of work since this 2002, but she really did maybe 3 or 4 different studies at that point in time, right around 2002, that hit the airwaves with a lot of receptivity. And this is one that people have been talking about for a while. So she looked at the census tracts up and down the East Coast for the most part, but and looked at fruit and vegetable consumption with each additional supermarket in their census tracts. So only 8% of African Americans in 2002 in the census tracts that she was looking at, which included most of the Carolinas. I think it was really in the Mid-Atlantic, so it may have included Delaware, I'm not sure. Had that census tracts that were predominantly African American had a supermarket in the census tract, whereas 31% of white census tracts did. and that was compared to fruit and vegetable consumption. And when an additional supermarket was in the census tract, she found a relationship between fruit and vegetable consumption that demonstrated a 32% increase for African Americans and 11% increase for whites. This started to point the finger toward the fact that those who perhaps were less or at higher risk, had less access, may actually benefit more from this kind of intervention than those who already maybe had access or were less adversity. This is another study that just recently came out. So Brian Elbel is at Cornell, and so this is another interesting study looking at the impact of a supermarket on a low-income neighborhood. It's interesting in many ways because he looked at minority parents and caregivers of children aged 3 to 10, and the study was conducted in the Bronx, and looked at differences between those who had a new supermarket in their neighborhood and those who didn't. He did not find that it improved the children's dietary intake. And this is one of the first that looks at the dietary intakes of children. All the others have looked at adults to date. My study just looks at adults too. So, I should say 3, but the question is then, should we bag this approach? A lot of people are debating this right now. I would say no. I think that it is still part of a comprehensive approach. We do still know that 30 million Americans don't have access to affordable, nutritious food. And I think one of the appeal of a approach like this is that it's not only about health. It has these multiple sector potential benefits, economic development. Supermarkets are anchor institutions. For example, in Philadelphia, one of the first stores to come online, has this amazing story where it'd been without a store for a really long time. When it went in, a big movie theater went in across the street. It's really revitalized the whole corridor, and you see that happening over and over again. I think I have a slide in here. This is Mari Gallagher, so she owns her own business in Chicago and has done a lot of work on this issue, but I love this quote. To my knowledge, no one of any credibility has ever suggested that access was the entire solution or that anything involving the complicated relationship between diet and health is simple. And then this is a great story of a dad who has a lot of kids. I can't remember how many. I want to say like 7. I don't know. A lot of kids. And he's got to go, like, on this is a bicycle, by the way. This is not as slick as it looks. It's not like motorized. So he after we started work in Cincinnati, I worked in Cincinnati with the Food Trust to help them establish a program. This guy sort of got found by the newspaper writer, and all of a sudden was all over the airwaves for the story of how he took his bike or walked and put all these groceries in this enormous bag. And you can watch the video. It's unbelievable how he does it. It's very telling about not only how important healthy food access is, but also how the stigma that's attached often to the fact that some people want healthy food and other people don't is sort of dispelled, because the lengths that this guy goes to get healthy food is crazy. None of us in this room would do it, I'm sure. And then here's some of the economic benefits of a financing program that have been communicated. So the Pennsylvania results, increase in tax revenue, jobs, and then job workforce development is obviously another one that's big. There's lots of examples of people coming out of the court system and getting their first job sort of in a food retail organization. So, and some, like ShopRite, actually have established programs to help people who are formerly incarcerated get a new start. It's kind of accessible. So research challenges, it can be messy, right? I think this is always interesting because as you guys, if you're researchers, like I know you and I were talking, you're kind of the data puller guy. it opens your eyes to the kinds of challenges that are really behind the scenes. I teach both quantitative and qualitative methods, and when you, like at Jefferson, for example, where we have a lot of docs and a lot of sort of medical minds in class, they'll say, oh, a qualitative, like it's all up to interpretation, you know? And we forget about how much interpretation goes into deciding which numbers you pull and don't pull and how we interpret them too. So here's some of the challenges that go along with this data, and one reason why I take some, like the Lee and Sturm articles and others sort of with a grain of salt. So this is a list of the stores that you would get if you pulled a supermarket list from Dun & Bradstreet. So some of these stores, so this is the number of registers, I think. Is that possible? No, 37 registers is not possible. It could just could be the number of aisles. So this is all because the name is supermarket, right? And so this is the total. This is the revenue, monthly revenue, I think. So the problem is that all of these meet the criteria of $5 million of sales a year. But for example, like La Esperanza supermarket. Now, it's really hard to say if it's really a supermarket or if that's a corner store in disguise. Or maybe Brothers Supermarket. I don't know. It meets the basic criteria, right? So some of it is in this enumeration, and this is just the start of the iceberg, right? So this is actually looking at data you have, assuming that Brothers Supermarket actually still is open, and that it really is right. Not only that it's still open, but that there hasn't been a new store that's taken over that space, right? So that it's not completely changed in terms of what kind of establishment it is. So what we end up having to do, and there's Stephen Matthews and another researcher, he's at Penn State. They recently did a study looking at these databases that you can buy. So Nielsen sells databases. Dun & Bradstreet comes with some of the GIS software and others, and found that there's about 50% of the information is wrong. So wrong in all different kinds of ways, but is just wrong, right? So what you have to do then, oh, and you can also get lists, by the way. This is a great data source if anybody wants to do this work. Online now of all the SNAP authorized retailers in your area. The USDA offers that online now. So you get these lists, and then what you have to do is hit the pavement, because you got to see if really these stores are still there, if their addresses are right, And so when I see studies that are large swaths of the U.S., I know for a fact that they did not drive up and down all of those streets, and that a lot of the data has error in it just because of the nature of the way that these things are collected. So that's one issue. Another issue is store quality. So I have this stinky fish on here because there's a store that a bunch of us walked in once, and the fish department clearly needed some work, and the stench was so awful that I'm certain whoever shopped there was not shopping there because they had any other selections. And so when we talk about store quality, the fish stink is one example, but we also hear a lot of other issues that come up with stores. Meat selection, that it has produce but the quality's bad. There's a lot of these like intangibles that come to life when you're doing these large, broad-scale studies that, may miss the mark. Neighborhood dynamics are another one. I put the railroad tracks, right, the famous, we live over here, so even if the store's here, I'm not crossing over this to get there, either because culturally I'm not comfortable there, or because technically there's actually a train and I'm not going to go over because it's not safe for me to cross the highway or whatever. And so again, a lot of these studies that are looking geographically are not taking into account this kind of issue going back and forth. There's also the importance of perception. So there's more and more studies, actually all of them now, I think, that are in the field, are looking at perception, because it seems like perception is really having a relationship with your consumption. So if you believe, even if it's true or not, if you believe that you're living in a place that's supportive of a healthy diet, you're more likely to consume a healthy diet. Again, this is early evidence back in 2012, but I'd expect for us to be seeing more of this. I think it's an interesting concept for us to be following. So, respondent bias is another big one. So, you know, when I continue to be astonished. You know, some of the big studies that have come out were telephone, landline surveys, you know. I don't know how many of you answer your telephone or how many of you are even, especially if we're talking about the populations that are most of concern, right? I don't think they're at home answering their landlines. Like, we're talking about young families, have a lot of obligations. Everybody has a cell phone. So it's becoming more challenging. I understand that, you know, people are now doing more cell phone based studies, and my study is going door to door, which is obviously heavily labor intensive, but at least you know you're really getting the residents who live there. I worry that some of these big swaths, which they report, I mean, they skew old and they skew white and they skew upper income because that's who answers the phone. The older people are still sitting there. God bless them. Anyway, what we have seen is that, you know, there is starting to be a turning of the tide, which I'm sure some of the folks who are coming later will talk about the trends. But one reason that and Philadelphia is, I'm extremely proud of the shifts that we were able to achieve there, not just in obesity among school children, but really Philadelphia was the only city so far that was able to significantly move the needle among minority populations, more so than non-minority, and obviously that's where the highest risk is, so that's where we wanted to move the needle. And what's sort of attributed to this is a comprehensive approach. So again, I sort of made fun of the IOM's, you know, enormous framework, but that's really, I think, unfortunately, the complexity of where we are. I think we're going to have to keep hitting this thing at multiple levels across multiple types of intervention. And so this is one set of the comprehensive approach that occurred in Philadelphia at the time. More grocery stores, improving access through the corner store initiative, expanding the farmers markets, providing nutrition education to SNAP eligible students, and that's through the SNAP Ed program and the comprehensive school nutrition policy work that's happening. And I know a lot of these efforts are also being mirrored here. So the next kind of wave of thinking in this work is saying, well, now that there's stores, we'll assume that's a good thing, but how do we move forward to say, well, how do we get people to buy the things in these stores that's the healthier stuff? Because let's be honest, the middle of the store is full of a bunch of processed food, which we probably want people to steer clear of, right? They always talk about shopping the perimeter. So we've begun to do work looking at strategies to increase sales on healthier items that are more carrot than stick. So I'll talk, you know, in a few minutes about some of the possible changes to the SNAP program, but one of the ideas that a lot of people are interested in is how can we incentivize stores, incentivize retailers, even, you know, like the Food Marketing Institute, which is the umbrella organization for food retailers, to actually undertake either on a volunteer basis or with announcements of commitments, actually undertake some of these efforts in a more significant way. So what we did was we did a study, a pilot study that's now being replicated, and that's the other NIH study that I have at this time, looking at how we manipulate products in store in a way that gets people to buy more. So if you think about marketing, are you guys marketers in here? No? So when you talk about stores, and unfortunately I had a different version of this that had some better examples in it, but when you talk about stores, there's a few different things. One is called a planogram. Does anybody know what a planogram is? Oh, okay, so here's your new vocabulary. And I had to learn all this too, by the way. I didn't come to this knowing this stuff. So a planogram is basically a description of what goes where on the shelf. And it's not narrative, it's pictures, right? So imagine like a cartoonish looking picture that has like Cheerios here 3 times, and then you're going to have one of, you know, Frosted Flakes, and then you're going to have like that. But it's actually specced out like that. So the guy who stocks the shelf uses the planogram to put on the shelf, right? So as interventionists, we think, how do I change the planogram, right? So that's one of the things we're doing. So a facing is how much looks at you on the shelf, right? So if I have 2 Cheerios next to each other, that's 2 facings of Cheerios, regardless of how many deep it is. So what we've been doing is we've been moving the placement, so moving it from lower on the shelf. Cheerios is a bad example because they always have prime placement, but so anyway, moving it from lower on the shelf to more front and center, right? They talk about eye level. It turns out it's a little bit below eye level. We'll say eye level. And then the number of facings. So the more increase of facings, the more you're attracted to that product because it's sort of more in your face, I guess. The other thing we're doing is called secondary placement. So as the term sort of connotes, it's putting that same product in a second place in the store next to something else that might be logical for you to buy. So a simple example would be bananas next to Cheerios if we're trying to push bananas. Bananas would be in fruit in the produce department, but they would also be, you know, you'll see those interrupted aisles where the stands have bananas. So we're actually testing to see how much lift you get or increased sales you get from some of these strategies in sort of a very specific way. And so the products that we targeted the first time were cereal, milk, beverages. We looked at beverages at checkout, so those checkout coolers, and then beverages on aisle, and then also frozen entrees. And what we found was we did have really pretty good results around milk. And milk is an interesting one because if you go into low-income areas, you pretty much exclusively see whole milk. And so it was quite a discussion to get them to change it from exclusive whole milk to adding some of the lower fat because, of course, the answer is, well, people only buy whole milk. We're like, but that's all you sell is whole milk. Let's just try another, one more. So anyway, but what we did find was that, unfortunately, it's very clear that milk consumption in America is going down quickly, at least regular old cow kind of milk consumption. But what we did was we kind of bucked the trend. So if you were to look at the data, a lot of stuff went down. So we looked at whole 2%, 1%, and skim in control and experimental stores. And across the board, everything declined except our skim milk and 1% milk sales went up a slight bit. So the stores were pretty happy about that because they obviously don't want to dedicate so much shelf space to declining product sales. And then the other was frozen entrees. So we had criteria, I have it here, but we went through a very, very thoughtful approach to figuring out what products we were going to select to target for this, change in placement and increase in facings and secondary placement strategy. And in one of the criteria was that we wanted to be a relatively high-selling item already, but that it would be a reasonable substitute for something that was even higher selling and worse for you. So banquet meals is the most top seller of frozen food meals in stores. You can get 10 for 10 is a really popular price point. So you can buy a Salisbury steak meal for $1, and they're extremely popular. So what we did is we identified those that were lower calorie, better for you among the selection of these really top high volume sellers and tried to push them above and beyond, put them in the secondary placement, the prime placement, and put the worst ones down below. So it's at the same price point, no difference for the store, but potentially better, shift in health. And there's about 100 calorie savings between the ones that we selected and the ones that would have been a top seller. So we did find success in moving the needle on those as well. And one of the strategies we use, it's funny, now you all go and you buy frozen food if you buy any, but the boxes typically get stacked like this, so you can't see the picture. And one of our strategies was to turn the box so that the picture looked at you. Again, one of these really subtle kind of solutions, but it seemed to work to move the needle. So I just walked through that with you. So a couple other programs and policy areas of interest. The SNAP program right now is under debate to move it from a entitlement program to state block grants. So the idea is that states then would be responsible for the administration of SNAP, and for those who do work in, on the policy side of this, there's a lot of conversation about whether or not that means that they would be restricting SNAP benefits to no longer allow for you to purchase anything with your benefit, but instead to only purchase specific items, and that perhaps that would be left to the states or open the door to, other federal guideline changes if this were to happen. So this is actually being debated this week, so it's really, really top of mind for a lot in the ag committees. Another effort that we were part of, and I understand the food bank also has an application, is we're seeing growing response to this double up food buck idea, which is happening in farmers markets. So if you're low-income consumer and you go to purchase fruits or vegetables at your farmer's market, you actually get more dollars back to purchase more fruits and vegetables. And this is an opportunity that some hospital systems have been taking advantage of too. So advertising, we've heard of Veggie RX. So I don't know if you've heard of this, but basically providing a prescription for fruits and vegetables that goes in tandem with these vouchers. So it's kind of like, you need to eat a better diet, here's your prescription to eat 5 fruits and vegetables a day or whatever, and then the coupon goes with it, and then maybe even information about where they can shop at the local farmers market. So these partnerships, we're seeing more and more about ways to do it. And I will say that I looked in depth at some data out of California a few years ago at one of these Veggie RX programs, and I was shocked at how BMI went down. There's something about that doctor word to do something that people, despite maybe some of you docs' beliefs in the room, they actually seem to do. So we at the University of Delaware are sort of in this large application, which I hear the results are going to be announced next week, to study the impact of this kind of nutrition incentive program across 17 states and in Washington, D.C., and also the state of Florida. We're going to be rolling it out in Delaware, too, I hear, although nothing official has been announced yet. The other interesting and exciting, I'm extremely excited about this, is the Farmers Market Nutrition Program. So you're saying to yourself, how many programs for farmers markets could we possibly have? Sound almost the same, but are slightly different. It's true. So Delaware was one of 7 states left in the U.S. to not participate in the Farmers Market Nutrition Program until this June. So starting in June, mothers who qualify for WIC will be receiving a $15 voucher that they can use to shop at the local farmers market. And you may say $15, what's that going to do? But the idea is that it exposes them to these closer locations. If they're interested in different kinds of products that their farmer might grow, they want to form a relationship with a farmer, get to know local agriculture, that they'll be able to do that. And there'll be 13, from what I hear from the Department of Ag, farmers markets that will be redemption sites for these WIC vouchers, which I think is pretty close to all the farmers markets in the state. And then next year, there's going to be a similar voucher program available for all seniors who are low income. So it's a big kudos to Department of Ag and Department of Health here. The last slide I have here is really about hospitals and some of the activities that are happening in hospitals. For hospitals, nonprofit hospitals that are interested in spending community benefit dollars, I understand that in December, although I haven't read the new regulations, there is a clarification that food is an eligible expenditure for those community benefit dollars. And so a lot of hospital systems have been doing work in this area already, and I'd expect it to continue to expand. So, Kaiser has farmers markets that they support in California and also in the DC area, both in their own hospital. Jefferson has done this too, and in the surrounding community. Boston Children's has just recently revamped their whole cafeteria to have local farm products as part of it. I don't know if that's directly tied to any of their community benefit dollars, but from what I hear, it's a pretty impressive revitalization of their cafeteria. And then Mainline Health Systems had an interesting partnership with the Food Trust when I left, where they were doing that sort of voucher double up food buck program, but they were also providing sponsorship to local farmers markets. And so there's a way to kind of get the word out to potential new constituencies across the street, if you will, back to that tracks, right? So we've got like Montgomery County, Philadelphia County, and there's a road in between. So the farmers market was across the street, and so trying to get more information out about healthy eating and where you can go in a partnership with the farmers market. So that's an overview, current trends, and some research. Thank you. Any questions? Yeah.
So that was really terrific. I didn't know much about most of this, so there's an opportunity to really learn a lot. So let me ask you a little bit about the corner stores, because we're always hearing how tolerable corner stores are. But I suspect, like everything else, there's a distribution, and some are trying hard, and some don't care. Is that true? What's the distribution like? Are there predictors of which corner stores are better, and would that suggest that there are interventions we could do with corner stores to help them improve?
It's a great question. Yes, there are certainly ones that need more convincing than others, and honestly, the way that the Food Trust has approached this, I think, takes a lot of that into account. So, they sort of allow you to build up as you go. So start small once you're adapting. Like I joked, I just when I was at the Convenience Store Association last week, we were talking about bananas as the gateway drug for corner stores because, getting into selling produce is. It's a totally new endeavor. It doesn't just sit there and collect dust. You have to actually care for it. You have to flip it. You have to make sure there aren't flies there. You have to know what can sit next to something and what can't. You often have to keep it refrigerated. Banana's not in that case. But just getting into doing that as a new part of your business model is relatively challenging. And so bananas, as it turns out, are the gateway drug. So once bananas fly off the shelf regardless of demographic, like everybody loves a banana. And I have thought deeply about this too, by the way, if you want to know. I think it's because there's no germs, right? And also it's very portable. So, not no germs, but you're not worried about like food safety with it because you peel it. Anyway, it doesn't drip like an orange. But so anyway, the bananas is a very popular way to start small and build up. Are there stores that tend to have more success than others? You asked that question. So yes, we found that stores that have a deli usually have a little more experience with keeping produce because you often have tomatoes and lettuce and things like that, and also some of that food preparation skill. Because one of the tricks, if you can move the produce, then you're doing great. Usually, the price point and the profit that you can make off of it is pretty good. The problem is when it starts to rot and go bad, and so doing that added value, making cut fruit salads or making another product with something that's starting to go that can help you save your loss, cut back on your losses for that product is a really important business practice. And so those who already have delis can sometimes adjust to that thinking a little bit faster. It's interesting because I think you use the word distribution when you first asked your question, and that's the biggest challenge.
I can't help it.
Well, there you go. But I'm going to apply it in a different way because that's the biggest problem is the distribution of the product. Because if you think about it in a simple way, which perhaps you already have, is that the more volume you buy, the cheaper it is, and corner stores don't need much volume. And they still need a low price because they're situated right in the heart of these lower income neighborhoods where people aren't going to pay a premium, for a, golden apple or something. So getting good product in small quantities at low prices is the biggest trick on the books right now. And so I understand in Wilmington, they're starting to work on partnerships perhaps with ShopRite or some other distribution channels so that they can get those smaller distributors.
Yeah, just to follow up on that, we're working with the Moore's Health and Prevention Services under a CDC grant right now. But one of the efforts with the corner stores is to figure out if there's a common distribution point that a lot of the corner store owners can actually get together and utilize as a central location for the distribution of produce and have it picked up. So there's some efforts going on, particularly in the east side of Wilmington right now. But I wanted also to address a point that Alison made earlier, and it's a great talk, but she mentioned that supermarkets are oftentimes play a role as sort of an anchor institution within communities. And I think that's true from an economic standpoint, but the corner stores also play a role as an anchor institution from a social standpoint in communities. A lot of the corner stores that we've had the privilege to work with, the owners for that matter, and had the privilege to interact with, those locations act as a strong point of social interaction for community members. So it goes beyond just going in there and getting your snack or your food and leaving.
Yeah.
But there's, conversations and stories and history being
They
shared.
take care of you too in there.
And
They ask
take care
where
of
you've
you, yeah,
been, where
absolutely.
so-and-so been, like, how's you doing? Yeah.
And there's a lot of history there. Usually, we kind of think of these places as being quick turnover, but there, at least in Wilmington, there's a lot of familial and history, historical ties. Corner store ownership being handed down to the next generation and so forth. So they have strong connections there. One thing that I wanted to bring up, there's currently a lot of interesting debate happening in the sort of bioethics and philosophy journals around social determinants of health and why are we really even bothering framing these issues within a social determinants of health framework rather than just an equity framework as a whole. And I think it goes back to something you mentioned earlier in the sense that the argument of access to food being a determinant of obesity, and that of course you're going to have research findings that come out on either way of that, either side of that middle. But what's interesting is that there's really hasn't been a discussion, as far as I know, in the literature, particularly around corner store or healthy food access, around it just being an issue of equity. We know that the history, given the history of supermarkets and the white flight from inner cities and so forth, and the subsequent economic problems that have happened. Because of that there is sort of a racial and equity-oriented issue.
No, there is. I mean, it's just not in the academic literature.
Right.
I wrote or co-authored a chapter in a book that came out in tandem with a movie that is. I can't think of the name of the movie. Is there any chance you might? Anyway, it was out just a couple years ago, but it was about this issue. Mariana Chilton, who's a close friend and colleague, has done a lot of work on hunger and nutrition. It used to be called Finding North. They changed the name of the movie right before they put it out, and I just remember the first name of the movie. But so you're right, and I honestly think on the West Coast, it's more palatable to frame it in those terms than it is on the East Coast. So, like places like Policy Link often lead with a discussion about equity.
Right.
Fundamental justice. Amy Hilliard, too, in Philadelphia, has done some work, and it wouldn't surprise me if she used some publications that go back to 2009.
Yeah.
That talk about, she did this big Du Bois project in Philadelphia, looking at the history of sort of redlining and racism in Philadelphia and neighborhood development, really, what that meant for planning and neighborhood development. So, there's some work on it, but you're right, it's not quite really not.
Touch on this, but how acceptable change to the marketing issues?
Oh, that's interesting.
Question number one.
Yeah.
And number two, has anybody ever tried any active interventions in the supermarket? So marketing's kind of passive, how you turn the boxes and where you put things, but is there any guides in the supermarket or an app or anything where you can say, donuts danger or something?
So there are.
Oh no.
Yeah, the supermarket tours is a really popular thing where the dietitian leads a tour. Most supermarkets now, not most, but actually I knew the number. 40% of supermarkets is what I was roughly. 40% of supermarkets actually have in-store dietitians on site every day, and 90% of supermarkets have a dietitian somewhere within their framework to provide dietetic advice to their consumers. So one of the chief jobs of dietitians, besides like offering classes and that sort of thing, is to do these tours, and they do it for kids and adults and seniors, and like how to shop your market if you have diabetes or whatever. So that kind of effort is relatively common. I actually also did, as part of the study, I didn't bring it up before, but like a milk challenge, which was really interesting to cut through people's thinking. So most people are pretty adamant about the fat content in the milk that they drink, that's the one they like the best. So if it's whole versus if it's skim. And so what we did is we actually had a sheet. So like imagine a sheet, if you don't mind me, like just a square, and it was sliced, and so it said 1%, 2%, skim, and whole. And they only got 3 kinds of milk. And of course, now that you know me, you know I didn't put whole milk on there. But so we went into the neighborhoods, and I said, okay, so guess, like which one's which, right? And I was in the store in the milk section, and only 7% of people could guess right all 3 varieties of milk. So despite their confidence when they walked up, they were really not able to select. And so that really opened up the conversation to say, well, hey, maybe you want to consider a lower fat milk because it didn't seem to taste any different to you. I feel like you had a second part to your question.
The question was how the supermarket chains have a different agenda, just likely making money. So how receptive are they to healthy marketing?
So as I suppose your colleague brought up earlier, there's a spectrum of receptivity. There's a large chain in the center of the country called Myers, which has a CEO who is a triathlete and extremely passionate about health and wellness. And he has insisted that this be a primary focus for all of their stores, and it's an extremely successful chain. So there's that example. There's another grocery store in Maine, Hannaford. They created their own guiding star system, sort of the app idea that you had. As it turns out, no manufacturer wants their product not to get a check or a star. So everybody wins, but some people win more. So anyway, but which was extremely well received. They even turned it into a business, and they sell it to other businesses who actually buy it at a pretty high premium as a way of creating loyalty. So that's the key. They see this as a way of supporting their customers, of differentiating themselves in the market, and of creating loyalty. Now, I just said differentiating yourselves in the market, right? So we want sort of a ubiquitous solution for America, because that's how public health and health practitioners think generally. That's where you meet resistance. It's like, well, you can give me parameters, but don't tell me to do this. Like, I will come up with my own special, unique, and better than my competitor way of doing this. And if you can feed off of that, then they're in 100%.
I think there was a question from Wilmington.
Oh, hi, Wilmington.
Yeah, we have a question over here. Hi, Allison. It's Liz. Great presentation. I was happy to hear that WIC. Can you hear me?
Yep.
Okay. I was happy to hear that Delaware WIC is going to be giving $15 vouchers for the farmers market. Is that a monthly stipend? Is that a monthly amount?
No, it's seasonally. That's how FMNP works.
Yeah, that's great. If it was monthly, that's not a lot if it's seasonally, but at least it's a start, I guess.
I understand. In Texas, they only get 5.
And then the other question was, you mentioned 3 hospitals that have farmers markets. Boston Children's, Kaiser Permanente, and what was the third?
Oh, they were kind of different examples, but I can get you a list if you want a lot of examples. I'll have to do an updated search, but the last one was Lankenau Hospital, which is part of Mainline Health Systems, and they're located on the edge of Montgomery County and Philadelphia counties, and what they did was sort of sponsor a farmers market program and partner to sort of promote going to the farmers market among their lower income and higher risk patients.
They have one in the lobby.
Yeah, there's a lot actually who have them. I can get a list of them. There was just a snapshot of it.
I think you said St. Francis.
I have another question. I always thought that the placement of produce in the supermarket was dependent on the brands, that there were incentives, or the brands were giving incentives to the supermarket to put their produce at the right place and everything. Mm-hmm. Didn't you have some issues with that?
Yeah, it depends. So there's certain things that are space that you wouldn't be able to, that's already been purchased, let's just say. A lot of the end caps are already purchased, but so an end cap is like, let's just say I'm shopping, right? These are the aisles, there's like a thing here. The end of the aisle, that space right here is the end cap. That's prime placement, especially the first 3 end caps when you walk into a supermarket is where you would be more likely to buy. So in any case, oftentimes you'll see that the soda manufacturers, sweetened beverages are primarily placed there. And in fact, in some stores, they actually own that part of the store. They own it. They can do anything they want to it. And that structure is theirs. They own it. You cannot touch it. Now, you can negotiate with the distributors to get more of different products on there, which is sort of the tack that we took. So we were interested in more water and diet beverage as part of the display, and so that conversation they were willing to have. So Aquafina is a product that we know, like Coca-Cola sells it. So anyway, so we did work with that. But then there's other sections of the store where that's not quite as big of an issue. Produce is one, quite frankly. Another is milk and dairy. The dairy industry doesn't do a lot of, hardcore negotiations for space. And then frozen isn't hotly negotiated either. So there's some places where they have more autonomy than others. Soda is the least autonomy. Cereal, they have some. Cereal, they buy like a section of the store, like a section of the aisle, but then within that section, you can manipulate. So you can't put, if Cheerios is a General Mills, you can't put it in the Kellogg section, but you can move it up within the General Mills section, right? And things you learn. Yeah.
One of the things I was thinking of while you were doing your talk was that so food can come from other sources than retail environments. And specifically what I was thinking of is like community gardens.
Yeah.
Do you track like community gardens, or what is there incentive instead of giving it to the stores to place better product to give it to neighborhoods to grow a garden during the growing season? Certainly as dependent on where you are in the country.
Yeah. So the growing efforts are growing. We in Camden, I did some work in Camden for a while. There's a lot of gardens, local community gardens. Obviously, there's community gardens. I think Tara was there. I don't know if she's still there. In Wilmington that are growing. So, the biggest issue though is seasonality and how much do they really produce, and what is the right sort of expected outcome of a community garden effort, right? And so I think sort of like asking the same question around supermarkets and obesity prevention, like what's the right framework to enter into this conversation? My perspective is that community gardens are about building community, are about placing a new emphasis on produce and where things come from and how they're grown for children and families. It's a place for people to come together. And I really think that kids, once they grow it, they're more willing to taste it, and that opens up their mind to consuming more in other places. In terms, though, of being a primary mechanism of, distribution or something like that, I think it's a little more dicey because it's often not, people don't want to use pesticides and so it's a little, you never know what you're going to get out of that garden that season because it's the reality of growing, depending on how specific. Certainly, too, the food bank here is doing a lot more work in getting into the emergency food system, which I didn't touch on any of that work either, but that's a whole other effort that's happening with Feeding America to reorganize their objectives and change their measurements so that they're not so penalized because lettuce doesn't weigh as much as it can. Like, how do you help people get supported for doing produce?
Thank you guys. Thank you.